Welcome everybody to December's edition of Cancer Prevention and Wellness, and we'll get started in a couple minutes. So welcome everybody. I'm Jeff Jagir. I'm your host for the Cancer Prevention and Wellness series. I'd like to welcome you to the December edition. This is sponsored by the Cancer Survivors Park Alliance. A couple of housekeeping issues. Everybody that's on the call will be muted. We nevertheless encourage questions, and we'll be monitoring them via the chat feature. This is a pretty important topic that we'll be discussing tonight, so I want you to be aware that it'll be recorded and will be placed on the Cancer Survivors Park website. That's cancersurvivorspark.org. And we are very pleased to welcome and introduce Susan Webb, who is a Bachelor of Science of Nursing, oncology certified nurse, a bone marrow transplant certified nurse, and a recently retired nurse navigator with the Center for Integrative Oncology and Survivorship at Prisma Health. She is a nurse's nurse. She's taught me most of what I know about how to interact with nursing, and we work together a lot. So I'm very happy to have her on our session tonight. She's going to be talking about cancer prevention and screening and early detection. But more than that, she's going to be talking about, the potential for lifestyle and affecting people's risk for cancer and some of the active interventions that are available for certain types of cancers to help prevent them. So, Susan, thank you so much for participating in our series, and welcome.
Oh, well, thank you. Thank you. Well, we'll get going. I am just delighted to be with you here tonight. And let me get my slides moving like I need to. So I'll invite you to settle in as we explore cancer prevention and screening guidelines, and as well risk reduction. We'll specifically focus on breast, cervical, endometrial, lung, and prostate cancers. And I'll cover common barriers and some available resources. So in getting started here, let's frame our topic with the following definition of prevention, and as it is specifically applied to cancer. The National Cancer Institute defines cancer prevention as any action taken to lower the risk of getting cancer. And actions that may lower the risk could include maintaining a healthy lifestyle, avoiding exposures to known cancer-causing substances, and or taking medicines and vaccines that can prevent cancer. So looking a little more closely at preventive actions, I'd like to offer some perspective from personal experience. And if you will indulge me that for a few minutes, my husband and I were Peace Corps volunteers from 1981 until 1983 in Zaire, which is currently known as the Congo. We served as public health volunteers, And during these 2 years, we lived in this village pictured on the left called Cessation. And this picture is taken from the back of our hut, which is similar to those that are pictured there. The picture on the right is children that are in the village, and I'm not sure if our picture is obscure, but there's a little fella on the right that has a large basin on the top of his head, and he's carrying a leg of a forest antelope, and he's going around the village trying to sell it to anyone. And I'm showing you this because the preventive actions in the next few slides illustrate strategies to reduce health risk. These principles are relevant regardless of the environment, and although environment certainly has an impact. So one of the preventive actions that we mentioned previously is to maintain a healthy lifestyle. In our roles as volunteers, we promoted this principle by focusing on starting life with a healthy diet and achieving a healthy weight. The slide on the left shows one of our health center workers, and the poster is picturing a mother that's nursing her baby. And the picture on the right is showing one of our visits to the health centers where we're weighing the children and monitoring their weight and their growth and development, and again, promoting a healthy diet. An additional strategy we noted earlier is to reduce cancer risk through avoiding exposure to substances that can cause or promote cancer initiation. So when we think of exposure to substances, we might think asbestos, benzene, diesel fuel, and such as that, but infectious agents may also increase risk. So let's look at a couple of examples linked to cancer causation. The first two pictures from the Congo illustrate how water is traditionally collected from a creek or a spring and carried back to the village for drinking, bathing, and cooking. And these water sources may be contaminated from runoff that could carry parasites, chemicals used in agriculture, or other cancer-promoting agents into the source. So this exposure may pose a health risk, of course, and the pesticide DDT was banned in the US a few decades ago, as many of you probably recall, but it's still widely used in other parts of the world. And in this setting, DDT, for example, could be a potential contaminant and an initiator of cancer development. The third picture shows one of our volunteers standing on a spring box. This is the finished construction. And this allows pressure to build up in the ground and force water to come out a small pipe that is at the base. So that eliminates some surface runoff and also contamination from people standing in the water that they're collecting. The far right picture is the beginning construction of an in-ground latrine to further limit exposure to human waste, for example. In our environment in the US, we're familiar with some of the substances I mentioned, like asbestos, but broadening the definition of substances, we're also aware that infectious agents can act to promote cancer. Hepatitis B and C are examples. And to be clear, however, these are not transmitted by waterborne sources pictured here. I'm just mentioning them at the same time, since it is an infectious agent that can promote cancer. Hepatitis B and C are spread through direct contact with blood and body fluids, not water again. So aside from illness, hepatitis B and C, these viruses can cause chronic liver disease, inflammation, and in turn, an increased risk of cancer. So a couple more slides here from the past. Taking medicines or vaccines were also mentioned in that definition from NIH, and we can decrease risk related to cancer prevention through these methods as well. And on this slide, we're vaccinating children on the left for childhood diseases like polio and measles. And while we're not focused on cancer prevention, of course, in this example, the principle of diminishing disease is clear. Prior to going and doing the vaccine campaigns, we would typically go to the village and do a lot of education to make sure that it was understood in terms of what the benefits were. In some cases, however, the benefits unfortunately were illustrated when the spread of preventable diseases took the lives of children in unvaccinated villages. And then relative to cancer prevention, though, back to that and vaccines, we have vaccines against the human papillomavirus or HPV and hepatitis B. Both help to prevent and diminish this risk. The vaccine against the HPV virus is highly effective in the prevention of cervical cancer, as well as some oral, anal, and other cancers affecting both men and women. The hepatitis B vaccine is available and is normally initiated at birth in the US. It's also available for adults. And some folks pursue that and also pursue it for travel purposes. There's not a vaccine for hepatitis C, however, there is treatment which may offer a cure and diminish the risk of liver cancer. Relative to medicines, there are also certain medicines that can decrease cancer risk, and tamoxifen is an example. It may be taken to prevent breast cancer for some women who are at higher risk. And so that's one of the examples that we have for that. Okay. So let's put cancer prevention in perspective nationally for the US, and then additionally, we'll start to discuss local statistics. And of course, we'd have to have some statistics to tell us where we are in all of this. So what do they tell us? And so looking at the national cancer health data, we find that cancer is the second leading cause of death in the US. Among women, breast cancer is the most common, accounting for about 30% of all cases. And among men, prostate cancer is the most common, accounting for about 21% of all cases. Looking at South Carolina now, specifically, the American Cancer Society estimates over 33,000 new cases of cancer will be diagnosed in 2022. And that is equal to about 91 cases diagnosed daily, which is an astonishing number in my mind. The four most common cancers in South Carolina are lung, breast, prostate, and colorectal cancer. So with the data we just reviewed, where do we go from here? Based on what we've learned to date, the good news is that we can have an impact on our health outcomes. This chart illustrates ways in which we may reduce cancer deaths by 1/3 up to 1/2, which when you think about it is also pretty astonishing. There are two domains depicted here. I don't know on your screens if you can really see very much of this, but I'll tell you a little bit about it. The little boxes on the right that are in yellow are the clinical domain, and it's one of the two domains depicted. And the second one is the public health domain, which is before, or rather below, in the pink boxes. So evidence-based actions in the clinical domain are primarily personal lifestyle choices. And that's pointing to the things that we have control over that can contribute to this cancer prevention effort. And so then below that, public health interventions center on policy, education, and delivery of clinical services. Taking a closer look at the personal lifestyle impacts, this information is illustrating 12 factors that are the most studied at this time. So what are the actions we can control here? Examples include diet, such as increasing fruits and vegetables, avoiding processed meats containing nitrites, or limiting red meat to about 18 ounces a week. Additional actions include limiting alcohol, avoiding overexposure to the sun, avoiding tobacco product use, and maintaining a healthy weight. Limiting these avoidable risks may lower your personal risk of developing certain cancers. So you indulged me with my slides, and I'll ask for another. As we look more specifically at our guidelines, it's worth noting that there are multiple organizations that create screening guidelines, and some of these may differ. Generally, guidelines that I will focus on are from the American Cancer Society. Some information may also come from the National Cancer Institute, U.S. Preventive Services Task Force, and the American Institute for Cancer Research, and others pictured here. And this is my disclaimer slide. So I couldn't resist sharing one of my favorite quotes from the original Pirates of the Caribbean movie. In this scene, Captain Barbossa explains to Miss Elizabeth Swann that the Pirates Code is actually more of what you'd call guidelines than actual rules. And I can't do the Scottish accent, but at any rate, or Irish, whichever it was. But I think that's the way we need to think of some of these guidelines. There are some variations between organizations, and your providers may have recommendations that vary slightly. Your personal recommendations may vary based on any high-risk factors that you may have for a specific cancer as well. And I would like to add that it's important for you to be familiar with these, and most importantly, to discuss them and partner with your provider to determine what's optimal for you. Most of these guidelines are very similar, but there are some differences. So in addition to differences between professional organizations and their guidelines, there are other reasons that the recommendations for screening may be very different for some individuals. Here I've listed some examples of these factors, and they may include things like genetic mutations, personal or family history, abnormal screening results that drive subsequent follow-up. Some examples that may change screening schedules include the finding of precancerous colon polyps, a positive HPV test on cervical cancer screening, abnormal mammogram findings, or an elevated prostate-specific antigen or PSA, or a suspicious lung finding. I will point up to the top of the slide where it mentions genetic mutations. These should be identified through a diagnostic clinical genetic test. This is not a 23andMe result, and no knock on that organization for the fun of looking into ancestry, but when it comes to your health, it needs to be a specific clinical genetic test. So why are screening tests recommended? There are several reasons. The first is that screening tests are used to help find cancer before symptoms are known, like an elevated PSA, for example. Screening may also help to find and treat precancers, for example, a colon polyp that is an adenomatous or a precancerous type, or find cancers before they've had a chance to spread, like a small suspicious spot on the low-dose CT of the lung. All of these may have a significant impact on either preventing a cancer or improving chances of cure and survival. And I think the quote that I've listed here, written here from John F. Kennedy, captures the goal of screening perfectly. The time to repair the roof is when the sun is shining. So in my mind, that reminds us that we need to be getting ahead of the forecast. Before we go all in on the screening practices, let's do a little knowledge check. I have several true-false questions here, so I'll read them and then we'll see the answers as we go through each of the individual guidelines. So the first one, relative to breast cancer screening, the question or the statement is women should have the opportunity to start annual mammograms at age 40. Colon screening, regular screening should continue until at least age 75. Cervical screening, people who have been vaccinated against HPV should still follow the guidelines for their age group. And then endometrial screening, reporting abnormal bleeding is important to evaluate for endometrial cancer, and that is especially mentioned after menopause. Lung screening, another true false. Early detection through screening for lung cancer increases treatment options. Prostate screening. If you are African American and have a father or brother with a history of prostate cancer, you should have a discussion with your healthcare provider to start screening at age 45. Okay, so let's now start to focus specifically on our guidelines and disease sites for prevention. So for breast cancer among women in South Carolina, this was the most commonly diagnosed cancer in 2019. These stats are from July of 2022 from the South Carolina Cancer Profile that was compiled by our Department of Health and Environmental Control, otherwise known as DHEC. But I wanted to give you a little statistic there to give a focus on, or a little perspective on the magnitude of our problem. So several of the primary risk factors include dense breast, family history of breast or ovarian cancer, a personal history of inherited risk of breast cancer, a reproductive history such as older age at first birth, or not having children and not breastfeeding, hormone therapy for symptoms of menopause, radiation, obesity, drinking alcohol, and a sedentary lifestyle. So there are other risk factors, and I guess that's the other disclaimer I didn't mention, but there are a lot of risk factors for all of these. So I've listed some of the ones that are across the board for most of the organizations. So our first statement goes back to our knowledge check, and it's true. Women ages 40 to 44 should have the choice to start annual breast cancer screening with mammograms. And the second and third guidelines suggest the ages for annual or biannual mammograms based on age. So it mentions continuing to get annual mammograms ages 45 to 54, and that at age 55, it suggests from the American Cancer Society that you may switch to mammograms every 2 years or can continue screening yearly. So this last statement illustrates one of the differences between some of the guidelines, and I have another slide that will show that shortly. So how long should these annual or biannual mammograms continue? The recommendation is to continue screening as long as the woman is in good health and expected to live 10 years or longer. We also recommend women be familiar with the look and feel of their own breasts and certainly report any changes to their healthcare providers. In some cases, women may have a known genetic tendency or family history and could benefit from additional imaging, meaning additional types of looking at the breast other than mammogram. So in addition to their annual mammogram, they may have a recommendation to get an MRI. This type of test can yield different images of the breast and is normally done on an ongoing basis for women who are at high risk. Lifestyle changes may not result in immediate risk reduction necessarily, but it's important to decrease the overall lifetime risk. And as mentioned earlier, tamoxifen or other medications may be prescribed to further reduce risk for those with specific family or personal histories or a combination of factors. In addition to the screening recommendations, the ACS or American Cancer Society also suggests that women be familiar with the benefits, limitations, potential harms that are related to screening. And as noted here, the benefits are finding pre-cancers or early cancers. And this probably should be bolded. I don't know that that significance can be overstated. Limitations may be related to the density of breast tissue and can influence the reading of the mammogram. And there can be false positives, which may result in additional tests or perhaps a biopsy. And as well, there is a potential for false negatives, meaning missing a lesion on a mammogram, the identification of that. There is a small amount of radiation exposure, but this is less than the general environmental exposure we get every day, year round. And the benefits of finding these early cancers certainly outweigh this risk. So this is the slide that I mentioned comparing some of the guidelines. And you'll see there are 7 different organizations listed there on the left. And then looking to the right, you can see the age that they recommend starting mammography. Most are around age 40. The age to stop mammography varies. And some say, when life expectancy is less than 10 years or at age 75 or with shared decision making. So this is just to illustrate that they vary. And again, to underline the necessity of talking with your provider about your desires and the benefits. So now switching to colorectal cancer, we note that in South Carolina, this was the 4th most diagnosed cancer in 2019. And some of the risk factors we'll review here are family history and a first-degree relative, personal history of colorectal cancer, adenomatous polyps or ovarian cancer. Race and ethnicity play a role such that African Americans are at increased risk. Additional conditions such as familial adenomatous polyposis and Lynch syndrome increase risk. And then there are lifestyle factors such as obesity, having a sedentary lifestyle, alcohol abuse, cigarette smoking, or diets high in processed meats or red meats certainly can influence cancer development. A personal history of long-standing chronic ulcerative colitis or Crohn's disease may have an impact, as does older age. So before we look at the screening guidelines, let's review who these apply to. The ones that I will focus on are for people of average risk. That meaning the guidelines that I'll focus on are for people of average risk. So average risk is defined as people who have not had any of the following. So have not had a personal history of colorectal cancer or certain polyps, no family history of colorectal cancer, no confirmed hereditary colorectal cancer syndrome, and no personal history of getting radiation to the abdomen or pelvis to treat a prior cancer, for example. There are basically two types of tests available for colon cancer screening. And so we see the stool-based test on the left there. And so an example of a stool-based test that many of you may be familiar with is Cologuard. And Cologuard uses technology to detect DNA and blood released from altered cells, and it can detect both precancer and cancer. It is intended to screen adults 45 years of age and older who are, again, at average risk, and is not a replacement for colonoscopy in high-risk patients or anyone that has had a prior diagnosis or condition that we mentioned earlier. Patients with a negative test should discuss this with their provider and determine what the follow-up is. Should they get a colonoscopy or when to repeat another stool-based test. False positives and false negative results can also occur in regards to this type of screening. A visual or structural test may be recommended. So the example of this, of course, is a colonoscopy, which means you are looking at the inside of the colon. For those with average risk, it's recommended every 10 years. And the additional two visual methods that are mentioned here should be done every 5 years. One is looking at the lower third of the colon, that is the sigmoid oscopy, and the CT there is an external X-ray to look at the bowel. And all of these require this similar preps. And so screening recommendations include starting regular screening at age 45, and this should be done with one of the methods we just mentioned. And you should have this conversation again with your healthcare provider and decide which one is best for you. And you will both be needing to keep in mind any risk factors that place you in a higher risk category. And again, I just would wish I could bold this in my speech for you, but no matter what you do, the most important thing is to be screened. So continuing our colorectal screening guidelines, these include a recommendation for people who are in good health to continue through age 75, and this is one of the true answers from our knowledge check. For people ages 76 through 85, the decision to continue screening should be based on their personal preference, overall health, and prior screening results. People over 85, according to the ACS, should no longer get colorectal cancer screenings, but I would add here that this also may be a personal preference and should be discussed with your physician. And again, emphasize no matter what you do, just get it done. Now moving to cervical cancer screening. In South Carolina, cervical cancer incidence was 14 between 2013, 2017, and HPV is the most important risk factor and is responsible for about 2/3 of all cervical cancers. So I mentioned HPV a couple of times already, and in addition to this virus, there are other risk factors, including immunosuppression, cigarette smoking, a diet low in fruits and vegetables, because you're missing those good protective phytochemicals that are contained there. DES exposure is a rare cause, but is relevant for women whose mothers may have taken this drug during pregnancy. And just for reference, it was discontinued in the United States in 1971. Screening recommendations begin at age 25, and between ages 25 and 65, the guidelines are to get a primary HPV test or testing that includes an HPV and a PAP every 5 years, or a PAP test alone every 3 years. Now, I realize that's a lot and it's confusing. And I remember when this was explained to me several years ago, when the guidelines changed, I said, okay, whatever, but I wasn't really computing all those ages and how the frequency of the testing. But the recommendations can be confusing, and they may vary depending on your providers and the organizational guidelines they follow. The results of these tests may change the ongoing follow-up schedule as well. So it's important to note that in some cases, a hysterectomy may not include removal of the cervix. And in this case, cervical cancer screening should continue. Additionally, women who have been vaccinated against HPV should, of course, continue to be screened as well. Women who have reached the age of 65 and have had normal screenings in the prior 10 years and no cervical precancer or other serious diagnosis within the past 25 years may stop screening. Women who have had a hysterectomy should stop screening unless the hysterectomy was done for cervical cancer or another serious condition or precancer. Another thing we'll move on to now is endometrial cancer and the risk factors. So with endometrial cancer, lifestyle factors include obesity, inactivity, and smoking, for example. There you go. Are you with me now? Things that affect hormone levels include estrogen after menopause, tamoxifen, the number of menstrual cycles over a lifetime, and polycystic ovarian syndrome. Age is a factor, family history, having close relatives with endometrial or colorectal cancer, which doesn't seem connected, but it is. Having had breast cancer or ovarian cancer in the past, treatment with radiation therapy to the pelvis to treat another cancer. So the American Cancer Society recommends at this time, at the time of menopause rather, that any woman be advised of the risk. And these are for women with average risk without symptoms. There are no endometrial screening tests or exams really at this time. But symptoms that you would want to report are those listed here: vaginal bleeding or spotting. And this is another one of the questions that we had in the knowledge check. Some women may be at increased risk. And for example, women who have had or may have had hereditary or non-polyposis colon cancer, Lynch syndrome, have a very high risk of endometrial cancer. If several family members have had colon or endometrial cancer, consider getting genetic counseling to learn about your family's risk, and again, talk to your provider. Moving on to lung cancer, it remains the most common cancer overall in South Carolina. About 80% of lung cancer deaths are a result of smoking. And so obviously this is one of those things that is in our control, although I realize it's not an easy thing to stop. And I will mention some resources for you at the end of the talk. Other risk factors include secondhand smoke, environmental exposure such as air pollution or radon, or occupational exposure such as asbestos. A dietary supplement called beta-carotene increases risk in individuals who are heavy smokers. Radiation exposure may come from a variety of sources, including radon and radiation given as therapy. So for example, radiation that may have been given to treat a breast cancer or possibly lymphoma. The risk of lung cancer is higher in smokers exposed to radon than in non-smokers. And in people who have never smoked, about 26% of the deaths caused by lung cancer have been linked to radon exposure. The organizations listed at the top of the slide all recommend yearly lung cancer screening with a low-dose CAT scan for people who meet the following criteria. They're 50 to 80 years old and in fairly good health, and currently smoke or have quit in the past 15 years, and have at least a 20-year pack history of smoking. And this is defined by how many packs of cigarettes that were smoked daily over what amount of time. So for example, smoking 2 packs of cigarettes a day for 10 years equals a 20-year pack history of smoking. In reviewing the benefits and risk for lung cancer screening, the primary benefits are a reduced risk of dying from lung cancer. So that's obviously huge. And secondly, it's true that early detection means that there may be more treatment options available if found in an early stage. So that is from our knowledge check. So risk of screening include potential for a false positive that may lead to a procedure, perhaps a biopsy. Radiation exposure is about the same as a mammogram. The benefits of screening are easy to see here. I mean, when you just look at the first one, reducing the chance of dying from lung cancer. But it is important to get the screening done, to talk to your providers and understand how to move forward with stopping if you're still smoking. So we've just reviewed the benefits and risks for lung cancer screening. So let's take a minute to put both these things in perspective with these current or recent findings. According to the American Lung Association's 2022 lung cancer report, less than 6% of eligible Americans, and that means those that meet the criteria we just reviewed, have undergone screening. So less than 6% who are eligible. Additionally, the 5-year survival rate is about 25% nationwide, not so great. But in contrast, the 5-year survival rate for those diagnosed in early stage disease is about 61%. So our problem is that only about 26% of people are diagnosed at early stage, which again speaks to the starting the screening and continuing. It also underscores the need for additional education for those who meet the criteria and for those who would like to quit smoking and take advantage of available resources to do that. So it's really important to provide counseling to people that currently smoke and offer resources for smoking cessation. A lot of people want to, they don't know how or don't have the support. The benefits and limits of a low-dose CAT scan should be explained, and additionally, they should go to a facility that has experience in lung cancer screening as well as treatment. If you stop smoking, your damaged lung tissue will gradually start to repair itself. So no matter what your age or how long you've smoked, quitting may lower your risk of lung cancer and help you live longer, and certainly healthier overall. Moving to prostate cancer, our state statistics show in 2019 that prostate cancer was the most common cancer diagnosed among men. And our risk factors here include age, being African American, and a family history increases risk as well as a number of known genetic mutations. Starting at age 50, men should talk to their providers. Recommendation for screening is an informed conversation with your provider. This is really important. If you are, and like I said, this should begin around age 50. However, if you're African American or have a father or brother who had prostate cancer before age 65, you should have this conversation earlier and perhaps start screening at age 45. If you decide to get tested, you should have a prostate-specific antigen blood test, the PSA, and that may be done with or without a rectal exam. So how often you are subsequently tested will depend on your test result and your own personal risk factors. I was checking the time. There are several potential barriers to care, and unfortunately, this remains the case in 2022 for many people. And some of these barriers include a lack of knowledge, misconceptions about procedures, and what schedule to follow. And you know, it may include a fear of a procedure like a mammogram or a cervical exam or colonoscopy. And some folks are just limited by that fear or their thought that they may be embarrassed in the procedure. Certainly there are financial barriers and transportation barriers, among others. Despite these barriers, I just can't emphasize enough how important it is to be your own advocate and seek help to overcome any of the individual obstacles that you have or those that you see for others, perhaps in your family. Voice concerns you have to your healthcare providers to locate resources and ways to protect your health. All right, so one resource in South Carolina is the Best Chance Network. This program is federally funded and provides breast and cervical cancer screening for low-income and uninsured women ages 30 to 64. And I've listed the web address here, and as Dr. Jagir said, the video of this, the recording of this will be available online, so you can refer back to that for the addresses and numbers that I'll mention. Smoking cessation resources are available, and a few of these are listed here. You can visit the American Cancer Society webpage on how to quit smoking or quit smokeless tobacco. In addition, you can contact the American Cancer Society by phone. Another option is available through state resources, and this one is 1-800-QUIT-NOW. One of our local resources for smoking cessation is through the Prisma Health Keystone Family Medicine Practice, and their number is listed there. And as we bring this presentation to a close, I want to focus on a quote from a paper written by Madeline Drexer, and she's from the Harvard School of Public Health. Her article points to the fact that the cancer miracle is actually prevention. It's not the silver bullet, the magic bullet that we think of in some cases. In a study from the American Institute for Cancer Research in 2017, they found that fewer than half of Americans recognize that alcohol, processed meats, high amounts of red meat, low consumption of fruits and vegetables, and not enough physical activity all have clear links to cancer. So while we continue to make advances in treatment, the focus moving forward is to better understand the genesis of cancer and mechanisms to intervene. While we can't control our environment entirely or exposures entirely, there's good science to support changes that we can make to decrease our own risk. Stick to the Science is a web page available from the American Institute for Cancer Research. It is fabulous. It provides the latest information about well-known and studied risk factors, and it helps to clear up some common myths. So it's well worth taking a look at and digging further into that available resource and information. So to bookend with information at the beginning of the presentation, let's review ways we can all help ourselves reduce our risk. So avoiding all forms of tobacco, getting to and staying a healthy weight, moving and aiming to get at least 150 minutes of moderate exercise a week in whatever activity we can. Eating plenty of fruits and vegetables. As I mentioned earlier, they contain substances known as phytochemicals and help to diminish cancer risk in a variety of ways. They're like the active ingredients in our food. Additionally, it's best not to drink, but if you do, to limit that to 1 drink for women and 2 for men. And protect your skin when you're out with clothing, hats, sunscreen, and avoiding peak hours of the day for sun exposure. Know yourself and your family history, and know your own risk, and get regular checkups and cancer screening. That's the most important. So if you're inclined to participate in research, I'm going to put a plug in here for our cancer prevention study at Prisma Health. I was fortunate the last 3 years to participate with this team and the august team pictured. We have enrolled over 900 participants to date. The focus of this research is to identify links to cancer development on an individual level and with the eventual goal of preventing cancer on a molecular level. And if you're interested in more information about the study, again, you can find the phone number on the recording and the web link at the bottom of this slide. If you enroll, the first visit is a 90-minute assessment, which includes an extensive personal and family history, health risk analysis, and body composition analysis, which is really kind of a fun thing. At the end of this visit and each annual visit thereafter, individual recommendations for modifiable and non-modifiable risk are reviewed, and any personalized recommendations that need to be made or referrals will be offered as needed. And we also take specimens of blood, a cheek swab, and a urine sample, and these will be collected for later research analysis. The subsequent visits, by the way, are much shorter than the initial visit. Finally, I'd like to share an excerpt from the Cancer Survivors Park Alliance purpose statement. It states that we seek to provide a venue where the entire community can come together to share stories and memories and celebrate the joy of living a full and purposeful life. So thank you for your attention, for joining, and most importantly, I want to thank you for engaging in self-care by joining the presentation. You additionally have the power to educate and influence those around you toward a fuller life, and this truly is, in my view, the strength and the mission of the Cancer Survivors Park Alliance. So thank you.
Thank you, Susan. That was really great, very, very all-inclusive. I am so glad that we have the technology to record that so that it can exist in perpetuity on our website. I know we have some practitioners on the call, and hopefully as they're talking to their patients and talking to them about screening, this will be a referral source that they can use to come and do really a very inclusive assessment of all the screening capabilities, as well as the lifestyle choices that we need to make sure that, I mean, the easiest cancer to get rid of is the one you never had. And it's also important from the standpoint of, while some of the screening recommendations over the course of our careers have changed, and obviously with colon cancer, it's happened in a younger population, and so the screening recommendations are to start the colonoscopies a little bit earlier. I think it's probably been in the last 5 years that lung cancer screening for the at-risk population has become more of a scientifically based, data-driven recommendation. But it is a situation where I think you quoted that the uptake has been really poor to date. Any ideas or recommendations as to how maybe we can reach out to those people and make that uptake better? Obviously, 6% is inadequate.
I think it's an education focus that has to come from providers on all levels. So any healthcare interaction hopefully can include this and promote this. You know, a lot of the visits have such limited time and there's so much information to cover depending on what you're in for, but primary care can help a lot in helping to stress this. And I think that's one of the best places we can start, in addition to venues like this and any public health education forum.
Right. This hasn't been overly conversational as sometimes we have, because I knew Susan was going to do a thorough job with this and going to have a lot of slides and a lot of information to share. I don't see any chat questions now. Again, we will have this recorded and it will be there and available for anybody to link to later on. But it is a very uninclusive state of the art as far as screening is concerned. And I think one of the things that Susan wanted to emphasize is that you can make a big difference in whether or not, even if you're genetically predisposed, whether or not you actually manifest cancer by your lifestyle choices. We have been working hard between the hospitals in our area, in the upstate area, as well as the Cancer Survivors Park Alliance to develop this cancer prevention and wellness series for 2023. And I think we've got every month covered, and we will advertise those at our next session. Our next session will be on January 12th, 2023. And we're actually we've had some local talent, we've had some national talent, and we're going to actually go internationally at our next session. We've had some people from Australia, from the sun coast of Australia, close to Brisbane, reach out to us in following our site at the Cancer Survivors Park. They want to do a very similar type process in Australia, and we've gotten to be friends with them. There is a nurse who went through a colon cancer diagnosis and was young when she was diagnosed, and as a nurse has written a book that has been something that I've referred to quite a bit, and we're kind of going to do a book report with her. So that's January 12th at 5:30. This will be 7:30 her time the next day. And of course, she can go ahead, even though it's January here, she might come to us from her garden in Australia, because it will be the July equivalent in the Southern Hemisphere. So hopefully, if all the technology works out, we will have an Australian speaker in our January session. And I look forward to sharing her views and comments and sharing her book, and hopefully that'll be a resource for later on. You know, one of the things that we do at the end of these sessions is share a quote. And you know, I was thinking from the standpoint, should it be something about gratitude? Should it be something about the holidays? But when I was really kind of considering what Susan was talking about, I just wanted to include a quote, which is kind of a Nike quote, where it said, "Just do it." We got something in the chat. Oh, well done, Susan. No question, just add a girl. but it's one of those things when you talk about the colon cancer screening test that is best for your patient, the answer is the one that they'll do,
Yes.
the one that they're actually going to commit to. So this is a quote from Glennon Doyle, who is a contemporary author from the United States, and she's got a number of quotes. You can look her up. Glennon is Glennon, Doyle, and so this is just something that has the inclusion of just do it. If you feel something calling you to dance or write or paint or sing, please refuse to worry about whether you're good enough. Just do it. Be generous. Offer a gift to the world that no one else can offer, and that is yourself. So from the Cancer Survivors Park Alliance and from Susan and Prisma Health and the CIOS, thank you. Happy holidays, and we will see you again in the new year 2023. I hope your holidays go well and that everybody's healthy. And we will say good night. Thanks.
Thank you.
Thanks, Susan.